I'm Lawrence Gray. I work across a few different places. I have a practice out at the Epworth with a few of us, but I'm also a PhD candidate at the Barwon Infant Study. So some of the data I'm presenting today is from that, which is quite interesting data in my mind at least. And the other thing that I wanted to highlight for people, which we've just recently started at Barwon Health, is a hearing loss specific clinic for children with sensory neural hearing loss. They've never really had a home in Geelong before, and we inadvertently have started providing one, and it turns out that having turned over this rock, there is a lot of children with hearing loss who probably were slightly underdone in terms of their early investigation in particular. So these are children who get picked up at screening, and then it takes a long time to get their initial investigations done. So if you have patients like that in your books that you sort of were going up and down to and from Melbourne, or that weren't sure quite what to do with, then please get in touch with us. It's in the main outpatients area at Barwon Health, or in the main paediatric outpatients area, I should say. So you can send referrals there. So just to highlight that for everybody, because it's pretty new. Some of what I'm going to be talking about today, I'm not going to quite talk about, but we'll see how far we get. I don't mind if we do more of your cases than anything else. I've got one case at the end, which is a bit sort of made up case rather than a very exciting case, which was really just to cover off on the case aspects. But I think the discussion's more helpful, to be honest. The first thing I wanted to talk about is some of the data from the Barwon Infant Study. So this study's now, the children are in their 7th year, but we actually started following them when they were when their mothers were 36 weeks pregnant. So we've got this incredibly comprehensive longitudinal data. We've got some really interesting findings from very early in life. And this is some data which I'm just about to have published in Journal of Paediatrics and Child Health, really showing that the burden of wheezing illness remains extraordinarily high. So 82% of the kids were taken to a GP with a respiratory condition in the first year of life. And if you dig down a bit further and look at why they went, almost all had viral infections. A smaller number had bronchiolitis. Dig a bit further, trying to find those phenotypes of the children who are going to be potentially the ones who are going to have asthma or more persistent wheeze. Half of the children had parent-reported wheeze during that first year, and then a smaller percentage again, but still a very significant number of children, 1 in 5 kids, had significant wheezing with shortness of breath or recurrent wheeze. So that's our could they be asthma cohort that we're so interested in. And really this data is the first data in a cohort of this size in Australia in 10 years. And it's showing that wheezing illness remains incredibly prevalent, which we all know, but it's still nice to see it kind of shown in a more formal way. And so I want to talk first about asthma and viral-induced wheeze. Telling you a few things you already know. Asthma is a chronic inflammatory disease of the airways. It's most commonly triggered by viruses, and in fact there are many asthmatics who really only ever have flare-ups in the setting of a viral illness. You don't have to have flare-ups at other times in order to be asthmatic. And we used to talk about the group of asthmatics. We'd say there was this group of asthmatics who presented quite late. They were sort of 3 or 4, they were having their first wheezing episodes. But I think that in the main, almost all children who are going to go on and have asthma start presenting much earlier than that. They start presenting at the same age as all the other kids who aren't going to go on and have an asthma. And so it's very hard to pull these two groups apart. Asthma remains very high prevalence, but this data is very old. This data's 15 years and probably a bit more old, because it was published 15 years ago, showing that the prevalence of asthma in Australia was more than 10%. Now, I can tell you without that our rates in Geelong are higher than that of childhood asthma. So at 4 years in the Barwon Infant Study cohort, it's closer to 17% of children have a doctor diagnosis of asthma. So that is a GP or a paediatrician has said, yes, I'm happy that you fulfil the criteria. So this remains very, very prevalent and very, very common. Most of you are probably familiar with the risk factors for asthma, but I wanted to talk in a little bit more detail about some of those risk factors and what actually is the risk. Because a family history of atopy and asthma does somewhat increase your risk, but actually when you look a bit closer, it's really maternal history of asthma, particularly of active asthma during pregnancy. So something to do with not just the genetics that you're endowed with, but with the environment antenatally that pushes your immune system into a certain phenotype. And if your mum's got poorly controlled asthma during pregnancy and there's a lot of immune function being directed in a kind of Th2 response, you're going to kind of drag the child in that direction. And again, referring to my own data, we can see at birth in our cohort, we've got umbilical cord blood from our children, and we can see that children who went on to have food allergies and asthma had quite a different umbilical cord blood profile at birth, which is depressing. You know, what can we do? Not much. But I think it really indicates that we're quite influenced by the uterine environment when it comes to these diseases. Now, smoking is an established risk factor. I'm not here to say that smoking is not an established risk factor for wheeze and asthma. It's very well understood. But interestingly, in our data, we aren't finding that association. Now, if you look at smoking in Geelong over the last 10 years, it's following the same trend that all the rest of Australia is following. And our smoking rates are declining, and they're declining fast. The group they're declining fastest in is pregnant women. So we've now got a cohort of women who, very few of them smoke, so less than 15%, closer to 12% to begin with. And then once they find out they're pregnant, that drops again quite sharply. So that women who smoke during pregnancy are actually relatively rare these days. And what's really interesting to me is that we've seen this smoking rate drop off a cliff, but that our wheeze rate has absolutely persisted. So that tells us that although smoking is a key driver of something like wheeze and asthma, it's far from the whole story. And in fact, some of these other factors, like microbial factors, microbial exposures, the immune programming that happens in utero, clearly remain really important. So that's new data which really hasn't been published before to show that. And it'd be very interesting what's going to rattle out over the next 10 years in Australia, because we've probably been very, very successful at reducing our smoking rates, although it's arguable in certain sort of subsections of the population. Overall, we've really done very well. And whether we see a decline in some of these smoking-related illnesses will be really interesting. Whether there's a lag on that and why there's a lag is up for discussion, I think, still. Pets are protective. Pets are really protective, interestingly, and you can own any pet. So I've chopped my data many ways, but you can own a lizard and you're probably at slightly less risk of developing asthma. We used to think it was all related to furry pets, dogs in particular. They carry a lot of different microorganisms that we don't. They introduce them into our homes. They fill up the dust around us with different bugs. But actually it is quite simply pets and pet ownership that seems to be protective. And even pet ownership by your mother during pregnancy is protective. Fish, yes. So it's not that I can say that fish are definitely protective, it's that I can say that if you exclude the fish or include the fish, you don't really make any difference to the protective level. So I think that the fish, we've got small numbers of fish owners, I've got to say. We've got 60% dog ownership and about 5% fish ownership. And if they own a fish, a lot of them already own a dog. Because once you own a fish, you're usually a multiple pet owner. Lizard ownership is out on its own, which may or may not surprise everybody. But they are remarkably protective. And dairy farms, it's been known for a very, very, very long time. Dairy farms are protective, particularly if you work with dairy cattle, particularly if you are someone who produces milk. So either you're a kind of someone who works in a milking shed or feeds dairy cows who are milkers. Even if you live on a farm, don't do any work, stay inside, but someone who works on your farm brings you dairy milk from your farm, you're protected. And that's not from our data, that's from other international data. But it's really interesting levels of protection that probably relate to the microbes we're exposed to, and we can start to see some of the same trends in Geelong, which is really interesting and heartening, I think, because probably that's where our best chance of success lies, in reprogramming some of these antenatal life courses.
So is that just with cattle, or has it been shown with sheep and goats?
I've never seen it shown for sheep and goats. It's only ever been for...
Dairy around this area, particularly in Tasmania, so
It's a good point.
the only cattle dairy we're talking.
That is only cattle dairy, and that's primarily European data. And I've never looked at it in terms of sheep and goats. I don't actually know whether anyone's done that. But a good point. Because I think some of our site-specific differences in Geelong come out in really fascinating ways in the data, and I can talk a little bit more about that. Now, viral-induced wheeze. It's just that. It's nothing else. It's just wheeze that happens when you have a viral illness. It's really a phenomenon of the preschool age group. They have these soft airways which haven't become craggy and hard like ours. They fill up with lots of snot because they're having lots and lots of infections. And then when they try and move big volumes of air and apply big volumes of pressure, big amounts of pressure on their airways, you get dynamic collapse. So the airways suck in as the child's trying to breathe in and collapse as the child's trying to breathe out because of the fast flow rate of air, causing low pressure, and things just collapse. It's early and it's prevalent, which makes it really hard to pick from asthma. And also, the controversies or the discussion, I guess, not the controversy, but the discussion remains around how do we deal with this group and how can we help this group? And do they benefit from salbutamol, and do they benefit from steroids? So I'm going to talk a little bit about that. But first of all, I want to talk about how you pick between them. Having talked about those risk factors and thinking about it, how are you actually going to try and determine whether or not someone is more likely to have asthma rather than viral-induced wheeze? So family history is relevant, obviously. Maternal history of asthma, very relevant. Atopy, other allergic disease, is very important. But interestingly, hay fever, which is rare enough to diagnose in this age group, admittedly, but hay fever is not as important as eczema. So eczema is a potent driver of allergic disease in a way that hay fever isn't. Hay fever is more of a kind of final effect of being an allergic person. You end up with grass allergies and hay fever we're going to talk about. But actually, eczema and the exposure of your skin to allergens in the environment sets you on a very inflammatory path, as opposed to meeting those allergens in other ways, either by inhaling them or swallowing them. So there is something called the Lack hypothesis, named after a man called Gideon Lack, which has really become very, very popular in allergy discussions at the moment, which is the idea that the eczema that you have that's poorly controlled allows peanut allergen and other food allergens to fall on your skin, and that develops your immune response into a pathological immune response, an allergic immune response. As opposed to if you keep great barrier function, if you've got the kids heavily moisturised, well-controlled eczema, potent steroids used early and often to treat flare-ups, then you create a situation where the only way they're exposed to allergens is via the oral route. So when you eat a food allergen, you develop a totally different, more tolerant immune response. So eczema is critical in the development of asthma. I don't think the age of onset's that helpful. I think children who are going to have asthma start presenting early. Viral wheezes obviously start presenting early. Previous bronchodilator responsiveness is partially helpful. I'm going to talk about that a bit more. And obviously, if it's not viral wheeze, if there's a non-viral trigger, then that's a pretty big red flag. But I'm going to argue, do you really need to pick between these two? No. I think you need to acknowledge that it might be difficult to pick between them, think about what could be the answer, and then just jump in. Because really, you're only going to know with the fullness of time. So this is why I want to talk about asthma management and salbutamol. I think in both these populations, it's always okay to try salbutamol. And whether or not you continue is dependent on the response. I know this is old news, but just reiterating that spacers are the way to administer. And really, the efficacy of a spacer versus a nebulizer, the only time that a spacer fails in its efficacy is in a child who is not able to move enough air to hear the click on the valve of a spacer. And that is a rare enough thing. And in fact, children who can't move that much air should be in hospital and probably shouldn't be being cared for in the community. Using a nebuliser while we're waiting for an ambulance obviously has a place. I'm not saying that. But I think that children who are getting nebulizers outside hospital, either they're getting them unnecessarily, and a spacer would do, or they're sick enough that they need to be in a hospital. And so I'm uncomfortable with their use, really. One thing I'm going to talk a bit more about how I communicate asthma action plans, but one message I try to get across to parents is that salbutamol is a medication which, if we take too much of it, can be bad for us. It can have toxic effects. However, it's a life-saving medication and we can deal with the toxic effects. So the toxicity of salbutamol is that we get hypokalemic, drives potassium into our cells. We become nauseous and sometimes vomit. Very, very tachycardic, very quickly. And children already have a baseline tachycardia when they've got a level of respiratory distress anyway, so it's not uncommon to push children up and over 200 beats per minute with their heart rate when you've given them lots and lots of Ventolin. But all those things are able to be dealt with. We can replace potassium, we can treat nausea, we can treat vomiting, and children can maintain very high heart rates for very long periods of time without becoming unwell. So it's far more important to see Ventolin as a life-saving medication which you need to use, and know that there might be toxicity but not get too caught up in that. And then when do I give steroids for these two conditions? So do we give it for viral-induced wheeze? What about mild asthma? Is there any evidence that steroids are useful in these conditions? I think the answer is that there is evidence that steroids are useful in viral-induced wheeze, not just in asthma. And that evidence is only a couple of years old from The Lancet, and it's really shown that the benefit that they showed was actually particularly related to hospital admissions. But what it did demonstrate is what we all kind of intuitively understood and used to struggle with, which is that if you have a viral illness, which is naturally an inflammatory state, an inflammatory condition, and then you treat that with steroids, some of that inflammation goes away. Some of that mucus secretion decreases. So some of those airways become less constricted and less likely to cause wheeze, and your breathing becomes somewhat easier. Now, we kind of know logically that must be the case when we give steroids. Things must change in these children. It's not that steroids do absolutely nothing. But it's nice to have some evidence to back up that there is evidence of benefit at a more, I guess, a higher level. The Children's Hospital guidelines don't reflect this yet. They would still say that it's not for viral-induced wheeze. If you're giving it, we need to give 2 milligrams per kilogram, and then the subsequent doses are based on whether there is ongoing symptoms. So again, the counselling around this is critical. We need to explain to our families that I'm going to give you this steroid, and it's going to be this dose today, and then I'm going to give you a script for the 2 other days that we might be using it for. But on the second day, I don't want you to have that steroid if you're not using your Ventolin regularly. If you're using it on the second day regularly, then have your steroid. But on the third day, if you're not using it, I don't want you to have your steroid. So that's a very different message from here's 3 days of pred, okay? And which is certainly a much easier message. And I'm not saying that we can't still pick our populations for certain messages. But I think we need to start kind of changing the level of understanding and education that sits around steroid use in asthma. Sorry, in under 2. So the evidence for the benefits, there used to be better evidence for benefit over 2 for viral-induced wheeze, but even in this Lancet study they showed benefit, some benefit, although it didn't reach a significant level, but you could see the trend towards benefit for those under 2 as well. I will flag one thing that we're trying to get a trial up and running here for something called OM85, which is to say a bacterial lysate, a kind of cocktail of bacterial bits chopped up finely, which has been used in Europe for a long time, given to children who present with viral wheeze to see if we can bump their immune system towards a Th1 response as opposed to a Th2 response and get them a little less wheezy and asthma-y. And I think hopefully in the next few years, we can get that up and running, and it'll be interesting to see whether that is also an alternative therapy we can add to our armament here. I'm not planning on reading this out. I'm more than happy for my slides to be made available because I'm moving quickly through them and I'm not trying to read everything. But I have a kind of spiel for my asthma action plan that again reflects, I think, trying to communicate something slightly different that's less mechanical. I think asthma action plans always suffer from being a bit too stepwise and not really flexible enough for people who are sensible and who know their child well and know their child's asthma well. I always try and get across the idea, a bit like the Ventolin, that I really want to use as much Ventolin as the child needs. So you can give Ventolin as often as they need, and then you need to look at your watch and look at how often that is to decide what you're really doing, what the disposition is. So if you need to give your child Ventolin every 5 minutes, you give it every 5 minutes, but you're calling the ambulance because you're down below an hour of giving Ventolin. If you're giving the Ventolin very frequently and you're starting to see that it's getting more frequent, you need to think, at what point am I going to see my GP? At what point am I going to go to hospital? And I kind of say a 3-2-1 rule. If you're at 3 hourly, you can stay at home for a little bit longer. You can perhaps pack the bags. You might need to work out who's looking after the other kids. You might be calling your husband. But what you're thinking is, now that I'm at 3 hourly, I probably need to call the clinic and make an appointment. Things might get worse before they get better. 2 hourly, you're allowed to drive in to wherever you're going, but you must kind of make your decision and know that once you're at 2 hourly or less, things are going to get worse generally before they get better. And once you're at 1 hourly, stay put. You've missed your moment. You can't drive anywhere. Again, you're calling all your supports because they might need to come and look after the other kids, but you are going to hospital in an ambulance once you're at 1 hourly with your Ventolin. And I try and communicate that idea, and I don't know how well it gets communicated, but I think it's a bit more nuanced than just, here's your asthma action plan, it's got these steps. It's really saying, I want the Ventolin to be a life-saving medication for you to feel happy to use it, but then to time your run for the hospital or for the GP or whatever it is, based on your Ventolin use. How do you pick the ones who are going to get really sick? Really vexed and interesting question, because we always worry about which ones am I sending home thinking, oh, maybe they'll be all right tonight, maybe they won't. Previous ICU admission is very, very relevant in Geelong. So we have a hospital which is extremely comfortable with sick asthmatics on the ward. So particularly, I'm talking the paediatric population, obviously. We are happy to have children who are receiving oxygen, high flow, intravenous, mag sulfate and steroids, and they'd all be managed on the ward. So they're not going to ICU just because they've got bad asthma. They're going to ICU because they're really, really sick. So if someone's made it to ICU, you should be very concerned that they have severe asthma. Peanut allergy, these are the children who die. So children who have peanut allergy and asthma are the ones who are at the highest risk of mortality from an asthma attack, which is slightly different from what we saw in this thunderstorm asthma, when we had all these kind of undiagnosed adults who probably had quite severe unknown allergic phenotype sitting underneath, and then had it met with a trigger that really set them off. There were no children died during thunderstorm asthma, because mostly those kids are fairly well known, right? 82% of them have come to you in the first year of life. Their parents are keeping an eye on them. We kind of know the parameters. And we've usually picked up peanut allergy. And then you enter that other group. So people who are poorly compliant with a preventer, teenagers who don't want you to know, they don't want you to look at them, they don't want you to lift their jumper up, they want to be left alone even when they're really sick. If there's a social context where they're not going to be well looked after, or where they're going to be exposed to a potent trigger like a lot of tobacco smoke, which drives an exacerbation, then they're at high risk. A little bit about preventers. Number one is my number 1, 2, 3, 4 and 5 treatment for preventing asthma. And by that I mean I cycle through inhaled corticosteroids if I feel that one isn't working. I said to the group yesterday, someone asked, why? Like, they're all steroids, right? Why are we trying different ones? And I guess I have a suspicion that certain delivery devices work better for certain kids, and they're able to activate them more, or they enjoy them more, they like the colour more, so they're more likely to use it and use it properly. So I try different preventers. We used to say that using combined inhaled corticosteroids with long-acting beta agonists was riskier in children than it was in adults. The idea being that if we flooded their beta receptors constantly with beta agonists, that when we really needed to pull them out of a troublesome asthma episode, their beta receptors would just have nothing left to give us and the Ventolin wouldn't work. The safety profile of combined medications continues to look better and better and better. So I'm not against using those medications if we've failed a good trial of an inhaled corticosteroids at an appropriately high dose. On the other hand, I think leukotriene receptor antagonists, they've effectively left my practice and I'm not inviting them back anytime soon. The side effects I find are just too unpredictable and too severe. So, terrible nightmares, changes in mood and things like that, I worry about in young children. I know they taste delicious. I also think that their efficacy is limited to a very small number of groups that we have no way to predict well. So sometimes you meet a kid they would just work brilliantly for, but it's rare and you would never have known exactly why it worked well for that kid. And as a medication to try, I'd rather try inhaled corticosteroids. One thing to remember about inhaled corticosteroids is we used to be able to be very bullish about our side effect discussion about inhaled corticosteroids. There's now evidence that there is a tiny effect on final adult height from inhaled corticosteroids as well as from oral corticosteroids. So asthmatics on inhaled corticosteroids will be a tiny bit shorter than they would have been otherwise. I just put that up to say that preventers, the inhaled corticosteroids have different top doses, and it's important just to check that you've got the top dose for your steroid that you've chosen to use. And to be honest, I don't carry them all around in my head. I refer to the asthma handbook, which is where this table is directly stolen from, unattributed, because I didn't do it, I should have. But really, the asthma handbook gives you all this information in beautiful tabulated form. It's very easy to use. There are some new treatments. So there is anti-IgE and anti-IL-5 around, which is not we don't get to play with, but the respiratory physicians who are dealing with really brittle kids starting to use these. And then I want to have a quick discussion, really, or mention what I think is going to be a really interesting group of medications that will come in, which is the oral, particularly, allergen desensitisation treatments. In Geelong, if we look anywhere else in the world, if you do skin prick testing, you find that most people who are allergic to house dust mite. Second on the list would be a grass pollen of some sort, depends on the grass that you're exposed to. In Geelong, and nowhere else that I've seen, we have higher ryegrass allergen sensitisation than we do house dust mite sensitisation. And that's because we are constantly exposed to much higher volumes of ryegrass than we are to anything else. So the Western Plains, the kind of prevailing winds moving from Adelaide to Melbourne, the funnel effect means that we see lots and lots and lots of it. It also means that we're, in the firing line for the next thunderstorm asthma. We would be just as likely to sort of bear the brunt of that because we see so much grass pollen allergen already. And we've got a bunch of people who are allergic to it. Probably higher than in Melbourne, certainly higher than in children in Melbourne. We've got more ryegrass allergy. So I think that allergic desensitisation therapies offer a really potentially helpful thing, but they're too expensive. They're unbelievably expensive. And I've only had one patient take them up because we're talking about thousands and thousands of dollars over years to get an effect. One thing I will say though is that a bit the same way as I said that if you've got eczema, it can lead to asthma. We also know that eczema exacerbations drive asthma exacerbations. So at the time that your eczema worsens, your asthma also goes off. The same thing happens for hay fever. So hay fever that's very poorly controlled during hay fever season is going to contribute to your immune system moving in that Th2 direction and becoming more likely to trigger an asthma episode. So if you have patients who you can assume are likely to be sensitised to ryegrass, then treating their hay fever can be a really powerful adjunct to treating their asthma. And I would suggest that lots of patients don't complain too much about their hay fever; they put up with it. But we do have medications that are simple that work well for hay fever, and we should be using them. Now, this happened yesterday where I talked too much about the first thing, and that's fine because it's the most interesting, I promise. I'm happy to kind of plough on and continue, but what I'd rather do is talk more about what questions people have or cases that they have in terms of asthma and wheeze.
With regard to the asthma, when you diagnose asthma in children less than 1 year?
So never is the short answer. So diagnosis of asthma still remains something which has to happen once they reach school age. You might become increasingly suspicious over that time course, and it certainly doesn't change what you do, the fact that you can't make a diagnosis of asthma. I think even before the age of 1, you can often see those children who have very severe exacerbations of wheeze whenever they get a viral illness. They seem to have some degree of bronchodilator responsiveness. They come from a family of other children with asthma. You're thinking to yourself, no way that's going to be anything other than asthma. And only some of the time you'll be wrong. A small amount of the time, but some of the time you'll be wrong. So we do hold off on making that diagnosis. You've reminded me of one thing I mean to point out too, is that we used to, one idea that used to be quite prevalent was the idea that below the age of 1, children couldn't be bronchodilator responsive, that they either lacked the receptors on their smooth muscle or that their smooth muscle was so poorly formed in their airways that it didn't really respond. That's been proven to be completely untrue. We have airway smooth muscle from birth, which contains beta receptors and is beta agonist responsive. So when I say there's no harm in trying, I genuinely believe there is no harm in trying. Will it be efficacious below the age of 1? Only in a very, 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 very tiny number of children. And that's because even though there is muscles there and they are helpful, it's not bronchospasm that's driving most of their illness, even in the asthmatics. It's the crud that's filling up their small airways that's the main problem.
Is there any role for adrenaline in acute asthma?
No. So as a life-saving medication when everything else has failed, absolutely, but not otherwise. And that's not because it doesn't work. I suspect it works quite well as a bronchodilator and for dealing with the kind of imminent collapse of somebody. But it's in a situation where you've already got really potent tachycardia happening already and children who feel shocking, you would make them feel infinitely worse and drive their heart very, very, very hard and very fast, all for the benefit of the bronchodilation, which we can usually achieve through other things which are less potentially toxic. Not to say we don't use it every now and then when we're in the deepest of deep trouble. Yeah.
I've got a couple of questions, if that's okay. Sorry, I missed the point. Are LABAs good or bad?
Oh, so LABAs, we used to say, we were very anti-LABAs. We used to say, well, we're worried about not being able to give children the Ventolin they need, or being able to give it but it not working. But that evidence has moved away from that position, and we're now all more comfortable using combined treatments in children. Certainly down to the age of 6 or so. You wouldn't generally find them any lower than that. And most of us who are using them in that between 6 and 10 would be fairly experienced and happy dealing with asthma. I wouldn't be advocating that everybody in the room starts doing that.
Okay.
Yeah.
And another question, exercise-induced asthma versus exercise-induced bronchospasm.
Yeah.
Are they two different things?
So I think that exercise-induced bronchospasm is more common and is a real problem for a certain subset of kids. And it's very hard to know how to deal with it because it doesn't necessarily respond that well to pre-treatment with Ventolin, even treatment with Ventolin at the time. It's usually just you need to stop the exercise and everything settles down. We used to talk about exercise-induced asthma, and I think that's... I don't know that... I think that's an unhelpful term. I think exercise-induced bronchospasm is a better term. I think asthma implies a chronicity that sits beneath all this, that even when they're not having their flare-up, that there is ongoing background chronic inflammatory change. And I think most of those exercise-induced asthmatics, or kids who got wheezy when they exercised, didn't have any ongoing chronic change. They just had some bronchospasm or some reactivity when they exercised.
But they do get the benefit of the use of Ventolin.
I think there's a significant subjective benefit to Ventolin often, and I think it can be really hard to pull that apart. And actually, in older kids, I like to do lung function testing to try and understand it better, particularly if they've got a really good history suggestive that they get some benefit. Then you put them on the exercise machine, you do pulmonary function testing when they're exercising, and you actually see if you can generate some bronchospasm, see if you can make things better. Yeah.
My question was about the ones we used to call fat, happy rattlers,
Yeah.
who thrive and do well but wheeze all the time.
So because nearly every child wheezes at some point in the first year of life, or 50% of them have parent-reported wheeze, but probably there's many more if we listened who be wheezing at other times. There's many different phenotypes within that, all of whom are well and happy and growing. And in a child who's got, Ventolin is really a medication not just for wheeze, as we know, it's for respiratory distress associated with the wheeze. We really shouldn't be just trying to make wheeze go away so that everybody feels better. If someone is a fat, happy wheezer, eating well, breathing without effort, smiling, but sounds like a squeaky toy, then I think leave well enough alone. I still subscribe to that. That message hasn't come across though, has it? But I think when I say we're right to try Ventolin, I'd still be reserving it for children who have respiratory distress associated with their wheeze. It's interesting sometimes, I think, to give a trial of Ventolin for children who are very wheezy to see if you can make it go away. Because I think that's part of learning more about that child's respiratory illness and about their function overall. Sorry, you've had your hand up for ages.
Yeah. For families that have a history that troubles parents, is it ever too early to perform allergy testing in young kids?
Yep. So up to about the age of 1 or so, children are developing food allergies. So if you do skin prick testing up to the age of 1, you've got this kind of, maybe it's 30% or so will have some food sensitization. Very few of those are actually food allergic, but there'll be food sensitization when you do skin prick testing. And then somewhere between 1 and about 4 or 5, they swap. So all the children who are food sensitized become aeroallergen sensitized, and nearly all of their food sensitizations wane. So doing it too early is going to show food sensitization as opposed to aeroallergen sensitization. But to be honest, doing it at all is difficult because sensitization is not the same as disease. And there are plenty of examples of children who are food sensitized on skin prick testing who we take to food allergy, formal food challenge, who eat the food just fine. And that doesn't mean that they're not at higher likelihood of becoming aeroallergen sensitized. They are. Even if they're eating that food fine, they're still more likely to be aeroallergen sensitized later on in life. But I think this is a very vexed and tricky issue. And to be honest, I'd rather you sent them to me or Peter Goss or someone like us to think about it, because I think that it's a trap to start doing too many skin prick tests and too many RASTs in these children where there's, somewhat nebulous histories often of sensitization or allergy. It's better to have a really targeted few tests that you do at an appropriate age with good explanations around them, which is the hardest thing.
And I have another question. Is caesarean section a risk factor for asthma?
No. So all the data on caesarean section looks less and less relevant in terms of some of these things. So there is a slight increase in asthma or in certain allergic diseases, not in asthma, but in some allergic diseases in those children who are born by caesarean section. But there's often other factors that are more important. And when we look at, my PhD is on maternal microbiome in particular, and all the microbial studies are showing that a caesarean section is much less relevant than we thought it would be. And most kids run to a norm or run to a kind of family mean quite quickly after they're born, regardless of birth mode. Kids who are born into a NICU, they're in a different group. And if you pick up that group, a lot of them have been born by caesarean section. That's why they were sick. That's why they ended up in a NICU. So there's lots of confounders in the caesarean section data, which I think are relevant to think about. So I think caesarean section is not something we want to increase our rates of necessarily, but I find it increasingly difficult to find strong evidence against it.
Can I ask you about the child that gives me the irrits? It's 10 o'clock on a Saturday night in Dalesford, the middle of winter, the roads are cold and icy, half an hour from Ballarat, an hour and a quarter from the Children's.
Yep.
9-month-old child, moderate wheeze, slightly hypoxia, 93%.
Yep.
The state government makes it too hard to do chest x-rays. Yep. Am I going to send them to Ballarat? Are they going to do an x-ray? Are they going to admit the child is a bronchiolitis, wheezy, virus, viral pneumonitis? What would you do that night if you're my locum?
So the difficulty with desaturation is that it's normal and completely expected in any viral respiratory tract infection. The degree of desaturation you can tolerate is arguable. My bias would be that once you're down into the low 90s, so below 94, you need probably a better plan than just go home, don't worry about it. Particularly if you've got some evidence, something else like some worker breathing or some evidence that there's some significant illness. Whether that's to Ballarat, it probably is, I suspect, not to the Children's. Ballarat probably wouldn't do an X-ray. They would be, like we would be, they would be very happy because we've got the capacity to watch and wait and respond to whether things got worse or better. And you can't do that from home when you're a locum doing a home visit or whatever. And so you have to, at a certain point, say, well, desaturation is a potential risk which I think is significant enough that you should get help. And we all know the reason. Once children are below 90%, they're falling down the oxygen hemoglobin dissociation curve really quickly. And in a hospital, we might tolerate them sitting happily between 88 and 92% and not intervene in any way, not even give them oxygen at that level. But that's in a hospital setting where we've got the capacity to watch more closely. So I would send them. I wouldn't necessarily send them to the Children's though. It'd be interesting, it'd be an interesting discussion to have about how many parents would want to go to the Children's in that setting as opposed to Ballarat. Because there's certainly a group of parents who want that level of comfort. But I'd argue that going to the Children's would be more likely to have them sitting in a chair in the waiting room rather than being actually watched actively in a short stay unit or an ED.
And you would use a ventilator and you would give prednisolone.
So I don't think there's nothing wrong with trying Ventolin. I don't think prednisolone wouldn't make any material difference unless they were clearly Ventolin responsive and you thought, well, maybe this is a really early asthma. But I would try Ventolin, even in a 9-monther, to see if it helped. If it did help, with a spacer, yeah. With a mask, you'd need a sealed mask. You couldn't have a mouthpiece. And the thing is that would give you more information because it wouldn't actually dissuade you from sending them to hospital. If it relieved their symptoms, it would actually make me more likely to send them to hospital because I'd say, isn't that interesting? We've now learned that your child's bronchodilator responsive. Maybe they've actually got a phenotype that's going to be more like asthma. They may get worse before they get better. Let's send you on. But you'd be satisfying your own curiosity. and learning more about that patient as you saw them down the track, I guess. Yeah. Not necessarily changing their care that night. Yeah.
Can you elaborate again on steroid use,
Mm.
particularly with bronchiolitis, asthma
Yep.
in very young children?
So there's still no evidence of benefit for steroids in bronchiolitis.
How to know the difference? No? So the typical presentation, they come in, they're quite weak,
Mm.
they're under anemia or
Yep.
there's bronchiolitis, then I don't know.
So bronchiolitis,
Courses of steroids already. No? And
Yep. So bronchiolitis, I think, looks different in the end. It doesn't look different necessarily in that moment as you examine them for that one time. But I think over the course of the illness, it looks different. So bronchiolitis, there's often much more crepitations. They sound wetter than asthmatics do and viral wheeze does. They've often got they've got those other features, like they're not feeding well anymore. They've gone from someone who was initially just noisy and now they're starting to show worker breathing. And so we have the benefit of watching them over time, and we know that group there is no evidence so far, we don't know. There's no evidence so far to suggest that giving that group steroids decreases the severity of their symptoms, decreases their need for oxygen or admission, and makes them less likely to need ICU or anything else. So we don't give steroids. Now, do I think that in a child with bronchiolitis, if you give them steroids, that you're not going to change something intrinsic in their disease? I think you probably do. I mean, why wouldn't the steroids be reducing the inflammation in that child's lungs? Of course they will be. But there's no evidence that changes their outcome, so we don't. And I think that bronchiolitis is a diagnosis which takes time and isn't necessarily completely apparent, unless they're clearly crackly as opposed to wheezy and they're the right age group.
But the reality in GP land is that I had several cases where I didn't want to give steroids.
Mm.
So it was tonsillitis, and that we observed when it gets more distressed than you go. But they had already several courses of steroids in the night before, and then you have a doctor who doesn't care.
Or you're the only doctor who's paying attention to their symptoms. I mean, I think there's two ways to spin that conversation every time. We have this conversation all the time, of course, along the lines of, well, I know you've been treated for asthma, I don't think it's asthma, this is why. And I think that all we can do is continue to have our own high standards for what we consider our practice and continue to communicate those and reflect them for our patients. And if they choose to go somewhere else to receive different advice, then that's up to them. But I think that we do a benefit if we can continue to push back against some of these diagnoses or assumptions that have been made before. And I think sometimes also explaining why steroids may have been given and why that was a reasonable thing to do is helpful, and why you're not giving them today. Because I still think that there is going to be plenty of cases where you think, I'm not sure. Maybe we will give 2 milligrams per kilogram of prednisolone today while we're trying the Ventolin, and I'll see them tomorrow and decide if we go on with that course.
Is there a role for seeding in caesarean patients?
No. So you certainly do pick up bugs and wipe them everywhere, but a lot of those bugs get picked up and wiped everywhere just as effectively very, very quickly anyway. So mothers who aren't separated from their children tend to kind of become fairly quickly inhabited by similar bugs, regardless of whether they're Caesars or not, regardless of whether they're seeding or not. Mothers who are separated from their children and go to the intensive care type unit, where they unfortunately, of course, become immediately colonised with staph and multi-resistant organisms, that's a much harder thing to do. But you're not given an opportunity to seed those kids, right? Because they're whisked away on the resuscitaire. So it's sort of a bit of a moot point. But seeding doesn't make a great deal of difference. What in fact sustains most of your early microbiome is your feeding mode. So breastfed babies tend to carry more lactobacilli than formula-fed babies because you're feeding that particular bacteria a substrate that it really likes. So feeding mode might be relevant in this discussion, but probably not seeding in my view. But
The formula
No. So I view formulas as being a homogenous whole. We've got very stringent recommendations and guidelines, well, not guidelines, laws in Australia that determine what can be in infant formula. Everything else around the edges is decorative and designed to move units, and that's fine. But essentially, the constituents of formulas are all very, very similar. And when you talk about probiotics, I've never seen evidence of probiotics having any beneficial effect on asthma outcomes. When you think about what a probiotic is, it's a bug, one species or two strains of one species. It's usually Lactobacillus rhamnosus GG with a few different proprietary strains that you've cultured. And you pour it in huge amounts, a single bacterium. If you look at their stool, there's almost none in there because there's still only a certain number of niches that bacteria can occupy. And if there's no niche, there's no room for them, they die. They just pass straight through or they get killed by your stomach acid. So probiotics are not effective for reasons that are obvious when you think about it. Prebiotics is the other thing which people talk about. So bacteria can eat lots of different things. There's only a few bacteria that are very fussy about what they eat. And so I guess there are some prebiotics that might select certain types of bacteria. So a prebiotic is the idea that you're providing bacteria food. They may be more effective than a probiotic, but I've still never seen any evidence of benefit in relation to something like asthma.
When you will not diagnose the bronchiolitis if the child is more than 1 year old, say for example, 18 months old.
Yeah, so between 1 and 2, I don't know, I'm never comfortable. They're not quite viral pneumonitis, they're not quite bronchiolitis, they're somewhere in between. So I'm still happy to call things around that age bronchiolitis if they've got the same features. Crackles, wheeze, increased work of breathing, decline in their feeding. That's bronchiolitis still. Whether or not you want to change the name of it and call it something else is just that. You're just changing the name. I don't think the phenotype looks very similar. Particularly if you've got a small child or a premature child, they're going to carry that risk for longer. And children who had significant chronic lung disease and things like that, they get bronchiolitic illnesses or bronchiolitis-like illnesses, I think realistically, close to at the age of 2. You know, we're waiting for the calibre of their airways to increase to the point where they can't get those symptoms anymore. And if they're very small or growth restricted, the calibre hasn't increased enough, so they look like bronchiolitis.
Just going back to allergy testing,
Yep.
after the age of about 6 and over, if they've got bad hay fever, is it worthwhile doing desensitisation to prevent later onset of asthma?
Oh, I don't think there's any evidence of that. I think mostly because asthma, by age 6 or 7, asthma is established. Now, there is a group of people who present with adult onset asthma, but they've probably always had asthma. So it's not that their asthma was truly adult onset, it's that their symptoms became severe enough to notice in adulthood. And if you did lung function testing through their life course, you would see that they had abnormal lung function testing from the get-go. So I don't think by treating their hay fever or treating them with allergen desensitisation you would necessarily be preventing their asthma, but you may be preventing the progression of their illness. But I'm not sure that there's evidence about that. I actually don't know, to be honest.
Since asthma in children less than 6 years old, then you can't have the lung function test, you will diagnose it on the basis of the clinical.
Yeah, absolutely. And it's always good to later do lung function tests if there's some dispute or disagreement down the track.
Question is that one.
Sorry?
Having said that thing,
Mm.
with regard to the exercise-induced asthma and the bronchospasm, when you would diagnose in such children that child is having asthma?
Well, exercise-induced asthma tends to appear a bit later. They tend to be school age. It happens when they're running around at school, less so when they're 3 and 4. So I think you've usually got a group you can do pulmonary function testing in. So I would use the pulmonary function testing to decide about the difference between asthma as opposed to exercise-induced bronchospasm.
So that would be probably after 6-7 years of age, even the 7 year of age child may not be able to do properly lung function testing.
So most good lung function testing labs can get 4-year-olds to 5-year-olds to successfully perform spirometry. We've got other methods as well, though. We've got forced oscillation technique. We've got a few tidal techniques which we can use that are specialised, but we're developing our skills in them. So I think we can, in the Bowen infant study, we've had 6-week-olds. We've done lung function testing on 6-week-olds with tidal methods. So there are options for the preschool age group. But you're asking a complicated question that you really only be able to get done at the Royal Children's Hospital Respiratory Lab, and it would, be a long process. Yeah.
Could I just ask, what's the strategy? What's the strategy for young children introducing foods to reduce the incidence of later on allergies? We're told.
Yep. So the advice is now clear. We were always wrong in advising people to delay introduction of food. So from 6 months, introduce all allergenic foods. And the ASCIA, the Australian Society of Clinical Immunologists website, has some fantastic resources on this for parents and for clinicians to go through it. Essentially, we used to say delay, 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 and now we say no, go for it. The exception is children who have very, very badly controlled eczema. There is an argument for doing RAST testing and even skin prick testing prior to introduction, not because you would necessarily delay introduction, but because you might actually choose to do an in-hospital or a supervised introduction of a food. So if you had a child with severe eczema who had very high peanut IgE on their RAST, I would be uncomfortable with telling parents, just go home and feed them peanut butter. I'd say, why don't we bring you in and we'll do a formal oral food challenge. If you did tell them all to go home and feed them at home, nearly always they'd be okay, because the evidence is that it's less than 8% of kids have a true food allergy. But the ASCIA guideline, so it's everybody at 6 months unless you've got severe eczema, is what it can be boiled down to.